Welcome to the NorthLakes podcast. I'm your host, Jeremy Oswald. Today, a conversation about high blood pressure with family nurse practitioner Emma Cole and registered dietitian Rebecca Crumb-Johnson, who are both providers at NorthLakes Community Clinic. Let's get started.
My name is Emma Cole. I am a nurse practitioner here at NorthLakes. I practice out of the Ashland Clinic and the Iron River Clinic.
Great. And we also have a returning guest. Good to see you again, Rebecca Crumb-Johnson.
Always good to see you, Jeremy.
But for those who haven't tuned in before, share with us what you do here at NorthLakes.
I am a registered dietitian and certified diabetes education specialist. I think that's the name now. And I go to Ashland, Hayward, and Iron River.
All over.
I'm all over.
Yes.
And I'm enjoying this. I mean, I kind of miss the snow, but the driving has been fabulous.
That is true. Yeah, there has been not a lot of ditch work.
Yes.
Today we want to talk about high blood pressure. And we thought the two of you would be a good couple to talk to about it. Want to start out with Emma? Just tell us how does the heart work and what is high blood pressure?
So I think that sometimes people can forget that the heart is actually a muscle. And so like any muscles, they have to work to do their job. The job of the heart is to pump the blood throughout the body. And a really high level explanation of the anatomy of a heart is that there are two atria, which are on the top, and two ventricles, which are on the bottom. And so the heart will pump blood through into the lungs so that you can get oxygen into the blood, and then pump that oxygenated blood out through to the rest of the body. And then it also works to bring that blood back to the heart to then get reoxygenated. So high blood pressure, which in medical terms we call hypertension, is when the force of that blood against the arteries or the walls of the arteries are consistently too high. We're not worried about a one-time high blood pressure reading. It's that over time where it gets, consistently high and then strains the heart and then the blood vessels as well.
And so why is that bad if that happens?
So that's a good question. Why would it be bad to have high blood pressure? Better or higher is not always better. And it can lead to some serious health issues such as heart disease, stroke, damage to the kidneys. And then you're overworking this muscle, which is the heart, which can put extra strain on it. It can make it grow bigger and then ultimately lead to damage within that muscle itself.
So I always kind of try to think of it as a tire, that if you put too much air in the tire, eventually it might not blow, but you're going to stress the tire and eventually it can blow.
Yeah, that's a really good way of explaining it because I think people can see that visual. I'm very much a visual learner.
Yeah. So if you pump it and pump it and pump it, it can only take so much.
Right. So drastically pop, but still like it's going to cause more wear and tear on that tire. You're going to have to replace it.
The fibers of the tire are going to start separating.
And those are things you can see when you do pump a tire too high over a long time. With high blood pressure, sometimes it's difficult to see the effects on it because it takes a long time, just like pumping up a tire would too. It's not something that happens overnight.
And so how does this happen? Like how does their tire get too filled up? So
there are quite a few factors that can affect someone with normal blood pressure getting high blood pressure or someone with high blood pressure maintaining that high blood pressure. We know that eating a healthy diet, exercising regularly, reducing your stress, limiting your alcohol intake, and not smoking can help maintain a lower blood pressure, but also reduce someone that has high blood pressure. Sometimes those aren't always helpful or effective. And so then that's when your provider would elect to start you on a medication to help bring that blood pressure down.
But there's other factors I've heard of. Like, what would some of those other ones be? Like, does age or genetics or?
Yeah, absolutely. So, both age, we expect people to have a slightly higher blood pressure as they get older. You can have genetic high blood pressure. Sometimes you can't. You're only dealt the genes that you're dealt. You can't necessarily change that. But then other things like obesity, diabetes, your salt intake, hormone levels, and even certain medications can raise your blood pressure as well. So it's certainly a discussion to have with your doctor to see, what of your specific factors are playing into your blood pressure readings.
What are the two numbers? And I always go and I'm like, you have 790 over 350. I don't, I know that's.
Oh my gosh.
Yeah.
That would be something to be studied in the medical journals, because that would be quite interesting.
But so
we have two numbers. Blood pressures are always reported in two numbers. You have the top number, which is called your systolic blood pressure, and you have your bottom number, which is your diastolic number. Now, what we call a quote normal blood pressure would be that 120 over 80. And the top number, that systolic blood pressure, is the amount of pressure that's occurring when the heart squeezes and creates a beat. And then the bottom number, which is the diastolic number, measures the pressure on the arteries when the heart is resting in between beats. Now, we know our heart pumps really pretty quickly, right? And so it's difficult for us to kind of understand that those numbers happen quite instantaneously. But once again, that's why over time it's damage to your heart.
Thank goodness. Maybe after this, we could just check my numbers.
Check Emma's numbers.
Yeah, you should really check mine after this. They're going to be through the roof.
Well, one thing, when I was learning way back when in college, a million years ago, diastolic, I always thought of that lower number as like dying, like the heart is in rest. So it's like down, so that was how I always remembered it, was that it's that down, it's dying, it's resting, so that's what that lower number is your heart is at rest.
I like that.
Is that typically the higher number?
No.
Okay, thanks. See,
it's the lower.
Okay.
Yeah, the systolic is, I don't think I had one for that one, but
I always remember it as South Dakota, because, like South systolic, Dakota diastolic, and, it makes sense, right? And that, maybe I shouldn't say this, but South Dakota is inferior to North Dakota.
Wow. Well,
yeah. For our listeners, Jeremy and I had nothing to do with
I'm so sorry if any of you are from South Dakota. But as a former Fargo resident.
Let the debates begin.
Well, Roosevelt liked North Dakota.
Health podcasts cause uproar.
Way across in Wisconsin.
Right. So Becca, how do the two of you work together? Or maybe tell us a little bit about, how nutrition can help someone with their high pressure or hurt, or how does nutrition factor in?
So a lot of times when I'm dealing with people with blood pressure, high blood pressure often goes with other diseases. So like you'll have high cholesterol, often you have diabetes. The three of those things go together quite a bit. So a lot of times I'm dealing like with all of those, and luckily it's kind of the same diet for the most part, So, because I'll have people come in and it's like, well, I'm supposed to do this for this and this and this. And it's like, well, if you look at it, it's kind of the same. So there is, I think like 20 years ago or so, there was some studies done with what we call the DASH diet. So DASH stands for Dietary Approaches to Stop Hypertension. Okay, so that's the DASH diet. And I was thinking, Jeremy, that I would maybe give you like a sheet that could be put in next to the.
We'll add that. Yeah, we'll put it in the notes for sure.
So you can
yes,
see
please.
Because I'll be talking about the guidelines. And they did 3 different groups. One group, they're like, okay, you guys eat typical American diet. We're not doing anything. Second group, they said, we want you to eat this many fruits and vegetables. And the third group was, we want you to do fruits and vegetables. And they gave them more guidelines for the diet. And actually, sodium wise, it was 3,000 milligrams of sodium for everybody. So that, which is, can be considered low sodium for a lot of people, but for a really strict sodium diet, that's not that low. So to give people a comparison, in 1 teaspoon of salt, there's 2,300 milligrams of sodium. Okay. And so you are looking at that sodium part when you're looking at the label. It'll say what the sodium is. So anyway, this DASH diet was like 45 servings a day of vegetables, which probably won't surprise anybody. We always want people to do their vegetables. But keeping in mind, that's 1 cup of like raw leafy greens. It's half a cup of chopped raw. it's half a cup of cooked. So often we do, like if you eat broccoli, you're going to probably eat a cup of cooked. So it's not as overwhelming as what people might think.
Absolutely. Like I am kind of ashamed to admit that it was only within maybe the past couple of years that I realized, 4 to 5 servings of fruit and veggies is really actually not that much.
No, and it's unfortunate that it sounds like so much. Sometimes I think we should say vegetables are a cup so we can say it's 2 or 3 servings a day. And I think that actually would be a better approach.
I think it would be too, especially, and then, understanding that 4 to 5 servings of fruit and veggies, not,
actually for the DASH diet, it's actually 4 to 5 of vegetables and 4 of fruit.
Okay.
So that's kind of where, can it be different? And that's where if somebody has diabetes, they might go, oh, that's kind of a lot of fruit for me. So that's something we would kind of deal with. So the fruit, though, is 4 servings a day, and a medium fruit is considered a serving. So I want to think of somebody to think of like a tennis ball. Okay.
Or an apple?
Yeah.
Oh.
Yeah. Apple, orange, the bottom of a pear, and some apples are very large, and that can be 2 or 3 portions. So we kind of, need to like think of, because fruit comes the way fruit comes. And a banana would be 2 servings. Because bananas are bigger, and 15 grapes would be a serving. So
how's that help high blood pressure? So is it like eat this instead of that, or there's actually things going on with vegetables?
Well, with all the foods they're talking about, because with grains, they're talking about 6 to 7 servings of whole grains. There's all this great nutrition coming out of this. So it's like high fiber. Potassium is really important for blood pressure, though, we don't want to supplement potassium because that gets into a whole new risk, unless you're on medications where you need the potassium. But magnesium is super important for blood pressure, and so a lot of foods we're talking about is high fiber, magnesium, potassium. We found all these things are very important. And then also, hopefully when you do vegetables, you can do fresh or frozen or canned that aren't salted. And you're not getting all that salt.
Or sugared, I'm going to guess.
Oh, yeah. But sugar doesn't, not as much research has been done with sugar and hypertension. But you tend to not eat as healthy of foods. And then you want to do the whole grain, 6-7 servings a day. So again, half a cup of brown rice is a serving. Most people eat more than that, So... dairy is kind of thrown in there too. A lot of people don't do dairy, and that's fine. There's other ways, but that's partially also calcium plays into it, and dairy has potassium in it. So, that's another. And if you do proteins, you want to do the lean proteins, and plant-based proteins are fine. And that's also where you're going to get a lot of these.
I always like that you kind of defer to me.
I know. I point to you.
I just want to say you don't have to. Like, I know I've got this.
But you're a resident vegan.
I know. So here's my vegan 2 cents. Not that it's about me, but it's like, it's a diet that works for me, and everyone else, they have a diet that works for them. So I thank you for deferring, but I'm not.
They don't know that I was pointing to you.
Well, I can.
I always like to make you feel better about yourself.
Well, and we all need that. Yes.
With the caveat that being vegan does not mean necessarily being healthier.
Look at me.
Oh, you can eat potato chips and be vegan.
Yeah.
But
and Oreos too, right? I think Oreos are
totally.
vegan.
Yeah. Oh, for sure.
I think a whole pack of Oreos every day and not be healthy.
Yeah. So
it's like any diet, you can mess it up. It's like organic, organic, some of the organic
bacon,
right. Or organic, candies. Oh, that's good that candy's organic.
So I'm sorry, totally derailed you. I apologize for that. So if I can just, it sounds like the balanced diet, it's good.
It's a lot of the DASH diet is just, it's not anything spectacularly different than what I would tell anybody. You want, your fruits and vegetables, you want to eat whole grains. I always say most nutrition books could be like 3 pages. If we would just, simplify it.
I mean, I hear this frequently when I visit the doctor. So why don't people do it? What slows people down from this obvious, and I bet you would say simple thing. Well, it's not. Sorry, there's my question.
It's simple, but it isn't, because it depends on the person. If we want to just talk about like US in general, we have a lot of processed foods. And also we've really drawn away from that. I want everything to be done quickly. So we want to make our food really fast, and so it's just not become as much of a priority. We have it in our heads, and I realize it can sometimes be more expensive to eat well, but a lot of times it's not. It just depends. And Jeremy, you and I have talked about this before in other podcasts, is how much work you want to put into it. Mm-hmm. A bag of brown rice is super cheap, but you got to cook it.
The labor.
Yeah. It does take longer.
Yeah.
Mm-hmm.
And I think, for a lot of people, it can be daunting to see that package and be like, whoa, gosh, it's going to take 45 minutes to get this. And my kids are screaming in the background and like, I got to get their homework done and I got to get them to bed. And, I need time to decompress after a long day. And yeah, absolutely.
Yeah,
that's true.
It's a lot, and so it's like, depending on what your life is. I'm big on batch cooking.
Mm-hmm. I was just going to say that.
I like to do a lot of leftover. Yeah.
Yep.
My favorite meal is leftovers because you just heat it up. One kind of caveat with the DASH diet that's interesting is they very specifically wanted you to do 4 servings of beans, nuts, or seeds, and that is a lot of the fiber, the magnesium, the potassium. So that's kind of interesting because typically you don't see that in some of the recommendations. So like half a cup of beans is going to be portioned. That's cooked. And then nuts, if you make a hollow in your hand, take your hand and kind of hollow it out. That's a serving of nuts, and nuts have great nutrition in them, fiber, but you want to watch your servings because they are mainly fat.
Yeah.
Just calorie wise.
Got it.
Yeah.
So it's all this, a diet that includes these things. It's offering nutrients to your body, which is going to help your heart and going to help with high blood pressure. Right.
And more, and they did show that the DASH diet, when the adding fruits and vegetables improved people's blood pressures, but the DASH diet significantly decreased blood pressures. And then they later went on to adding studies where they, decreased the sodium. And so they did like 3,000, 2,000, 1,500. And the lower the sodium was, the lower their blood pressures fell. And it was very significant. It was better than some meds. So
awesome. Yeah. So here's another broad question. Is there a difference between high blood pressure and heart disease?
Absolutely. So I'm glad that you asked that because there is a difference between it. High blood pressure, like we reviewed, is the pressure inside your arteries. Now, is that the same as heart disease? Which it's not. You can have structural heart disease, absolutely being different than your high blood pressure. And then, you can have heart blockages inside the vessels of your actual heart. You can have high cholesterol. So these are all, different than having high blood pressure. And so, one of our jobs is to educate our patients, yes, you have high blood pressure. You don't necessarily have heart disease, or you have heart disease, but not necessarily high blood pressure, or you can have both. So it's not, they're not, one in the same, and they're not, always, or they're not always coming separately.
Got it. So if you're a podcaster and wants to just synthesize things, you shouldn't. You should find the two. Okay, good. Just want to know, like all you podcasters out there. So how do the two of you, do you collaborate at all? I'm not here in the clinic, so I'm not sure. Like I'd like to think that, everyone at the clinic, you all get together and you help everybody out, but I'm not here. So does that happen? And how do you guys work together?
If I could, I would send all of my patients to Becca every day, all day.
Well, then I'd have to work.
But then she'd have to work more, and then she would get less time with each patient, and that wouldn't be fair either.
Why do you want to do that?
Because Becca is the expert in this, and I'm not. I mean, I think people expect medical providers to have so much education on nutrition, and we really don't. We get very little education on nutrition. I can't speak to what doctors receive, but my understanding is that they also receive a small amount of education specifically regarding nutrition. And so, I mean, Becca's done her entire education on nutrition. And so to me, it's better for the patients to go meet with her and get all of the good information than for me to tell them a few blips of the information.
And it's also time. I mean, when you see your provider, there's a lot of different issues you have to deal with. You get 15, 30 minutes sometimes for an appointment, so I can sit down with somebody. The first appointment, I block an hour, and I'm saying very specifically, what do you eat during the day? What's your work schedule? Who do you need to cook for? How much can you afford certain things? Providers don't have that time, and it's not their fault, at all. So that's the big advantage, is that I can really sit down with somebody and figure out those issues. And, making food for people is complicated. It's emotional and all that. So I can talk about, where do we want to go with this? What are you willing to do? Just handing somebody a sheet isn't going to do it. It doesn't do it for any of us.
No,
right.
It doesn't.
For a rare person, it does, but very rare.
So can you continue to answer that question then a bit about like, how do you help people? Like, what are some, and I think we've probably talked about this before, but like, what are some quick things, or not even quick? How can you help people? Like,
well, again, it always starts with like, what are you doing now?
Mm-hmm.
Because I can hand people beautiful meal plans.
Yeah.
And it's meaningless. And so it's like, what are your cooking skills? How much time do you have? So, it's individualizing. That's how you help. And it is like reading labels, and, so just like example, if you see low sodium on the front of a label, that means, so if you have soup, commercial soup is very high in sodium. Then you have low sodium soup. The low sodium soup is compared to the original soup.
It could say lower sodium.
Yes.
Yeah. So the definition isn't like it's a lower than a certain amount of sodium. That's not how it works. It's compared to that thing. So you still need to look at the label and say, how many milligrams does this have? So I can teach people that way. Yeah, I'd rather you do the low sodium soap. That's great. If that's what you're willing to do, wonderful. But look at what else you're doing.
And Emma, how does that, so it must be nice to know that you have a partner in this, that you're like, you don't like, oh, good, Becca's there. They're going to help this person. It must be nice to know that you kind of have this resource in Becca and the rest of North Lakes to help you with your job. It's
such a relief because I know that my patients, our patients are going to get really good care from Becca, and it's going to be very comprehensive and well thought out and individualized because, like we've said, everybody is different. And what might work for one person is definitely not going to work for the other person. For example, I have 4 kids at home and I live in Duluth. And so it's, when I'm in Ashland, it's a 90-minute drive. By the time I get home, you can bet they're screaming at me to get that dinner on the table, like before I got home. And so, finding that individualized response is important for each person because we're all different.
Well, and it's vice versa too, because if I'm working with somebody and I'm like, they're doing everything they can do, and I can come to Emma and say, we need to talk meds more. We need to talk, whatever interventions you're going to do. Because you do have those folks that they're trying really hard and within their abilities. So then we need to look at other options. So it's that back and forth conversation of how do we help this person.
And if they're seeing another provider here, you may loop them in as well.
Right.
Absolutely.
Yeah. Yep. Right. It's just like we all have insights, and our patients have all told us different things. And sometimes when I say something or the provider says to me, and I'm like, oh, this makes so much more sense, and so we can treat that whole person. So the person's in the center, so we know what's going on.
And we all have different ways of eliciting that information.
Mm-hmm.
Like I might have been focused on XYZ during our visit. And, the hypertension, the high blood pressure is part of that, but not the whole reason for the visit. And then, so I don't get that information out, but then when they go meet with Becca, she's able to kind of hone in on some of that and get more information out that really is going to help provide better and more comprehensive care to the patient.
So what are some other things? What else about high blood pressure should we touch on?
Can I tell you my favorite high blood pressure story?
Yes, of course.
So my brother, who's my older brother by 6 years, he was getting some issues with his eyes, and he went in, and it turned out, I think it was like a macular degeneration thing. And so the doctor said, we're going to have to put a shot in your eye. And so then they checked his blood pressure and it was skyrocketing.
After Sorry.
I know. So the poor guy, he's like, oh, we're going to do a shot in your eye. And then now let's check your blood pressure. And the person taking his blood pressure said, well, Mr. Crumb, your blood pressure is really high. And Rex is like, you just told me you're going to put a shot in my eye.
I think anybody's blood pressure would be high after that.
So, it's just one of those things that's stress. That's like that one-time stress thing that makes your blood pressure shoot up. And, and then the next time, I think he still gets a little higher blood pressure every time they do it. But
I can't even think about those.
I know.
I don't.
He's kind of used to it now. I mean, he has to do it like every 2 months or something. But yeah, it's so just that. But if Rex had a shot in his eye every single day, that would be.
And I think that's a really good point, because we don't have someone come into the office and then, arrive and have high blood pressure and go, oh my gosh, right now we're starting you on meds today. You're going to die. We're not going to do that. Because we don't know what's going on. We don't know, are they very anxious to come here today? Is that something that's causing them so much anxiety that it's raising their blood pressure? So a lot of times we will, do a full assessment, have them take their blood pressure at home. They can come into the clinic for a blood pressure reading without having to see a provider. And, it's something that we will look at over the course of a little bit of time before, saying, stop right now, do this.
Well, white coat syndrome is a real thing.
It is a real thing. So that's what that's called. White coat syndrome is when people have high blood pressure only when coming into the office because it causes them so much anxiety. And so we really need to differentiate between white coat syndrome and true hypertension. Now, it gets a little deeper that there are other medical conditions that can cause high blood pressure. So then we also have to find out, is this something that's caused by a different medical condition? But
and just to say, team-wise, the nurses that we have will call people when they're, doing their blood pressures at home, to find out what's your blood pressure and, call them periodically so you can get a better picture of what that blood pressure is. So that's that team management and home management.
Don't we have a device that some patients take with them and then they're able to, it's just immediately uploaded to their chart?
I'm not sure about that, but I know that we do have loaner blood pressure machines that we can send with patients to take home and check their blood pressures.
I think it does have that capability. There's just a lot of time.
I overdid my question.
Chart.
No, that's okay. But I don't know if that, I don't know if we have that capability, because those machines are going to be much more expensive.
Got it. But
there's some like Bluetooth ones where it could connect to your phone that are loaners. So.
Got it. But
I don't know that they go directly into their Epic chart.
Yeah. Got it. I over asked.
No.
But I should, the real question is that there are ways that NorthLakes works with patients so that they can monitor their hypertension
absolutely
at home.
Yep. And I mean, we know that cost is a barrier to a lot of this, to the eating, to the preparation, to the meds, to the checking of your blood pressure. And so we have a lot of different ways of mitigating that. You can come in and get your blood pressure tested. If you want to come in daily, we can make that happen. That would be a little bit more difficult for us to understand if it's truly white coat hypertension, because you're still coming into the clinic. But it is an option. We can send you home with a loaner blood pressure cuff that the nurses will teach you how to use. We have the CSA program where we can help get patients fresh fruits and veggies during, the agricultural season, so that, we're helping to mitigate that cost. And I think they come with recipes too, right?
Yeah, and that's the farm to patient program. So if you go online, you can go on there and there's an application. It's a great program.
It's amazing. And it will open your eyes to the wide variety of vegetables that are available to people in this area.
It's pretty fun that the location I work is a distribution point for that. And it's just fun to see like these boxes of vegetables just showing up and people pulling up, and there you go. So, I mean, it's not for everyone. It's a prescription.
Yep.
Right. And, when I'm talking to a patient and it's, I'm assessing their cooking skills and also what they're willing to eat. And then I'll say, oh, you'd be a great farm to patient person. Let's get your application in, because I know they're really going to use it.
Yeah.
And they love it.
It's like Christmas every week.
Yeah, I know.
That's the way I look.
Every other week.
Yeah, well, whenever it happens, it's just like, ooh.
Unless it comes with kale. I hate kale.
Oh,
see, but then you give it to somebody else.
That's true. And then it's Christmas for them.
Yes, exactly.
What? Kale?
I hate kale.
Well, thanks for coming in.
I just glanced at the clock to see if it was time to be done.
I think we can wrap this up now. No? There's
I'll give you all my kale.
So far, Emma, you have isolated the Dakotas and kale eaters. So let's keep it rolling.
So speaking of hypertension,
what could she do for the trifecta?
Right. Well, and I know that when I go to the pharmacy I go to, they have one of those high blood pressure machines, that you can check, and relieve me. Like it does. Are they accurate? Is it worth doing? And you don't know where I go.
Yeah, It's better than nothing. The problem with it is that cuffs are not a one size fits all. And so you really need to individualize the size of the cuff to the patient's arm. If your cuff is too big for the arm, you're going to have a artificially low blood pressure. If the cuff is too small for the person's arm, you're going to have an artificially high blood pressure. And so, the cuffs, at the pharmacy or Walmart or wherever they are now, that's great. That's a starting point, right? It's getting you in to see it, but I don't want people to be like, oh, this is my reading. This is what I am. This is, they really take it too serious. And it's something that, like I said, it's a starting point. We get you into the clinic, we start to do that. And even home cuffs, like we will do what we call calibration with the cuffs. And we have you bring your home cuff in to the clinic so that we can compare it to our clinic machines. And so if it's a 20-point difference, that when you go home and take it, that you have to, adjust it in your mind by 20 points or whatever it may be.
So do you have an opinion on the wrist cuffs?
Once again, if it's what you have, I think that's fine. If it's what you have access to, once again, it's fine. I tend to think they're not as accurate. But for example, when I worked in the ICU, there were patients where we could only get a wrist blood pressure. And so we took what we could get. Or, there's a patient we could only get one on their ankle or their thigh. And the gold standard is your upper arm. But we have to understand that might not be realistic for everybody.
There's a lot of medical, I'm doing the air quotes, information available. How is that good and bad? And, I know wow, my knee really hurts. I'm going to the web and I'm going to dig around and I'm going to find whatever thing, that I trust. How does that help or hurt you? Or how is that good or bad? Or,
you want to go to reliable sources, the American Heart Association.
So it's good.
Yeah. Reliable sources. The first place I would go is the American Heart Association. I mean, they're going to be using information that's based on science and studies, and that's a good place. And it's going to be very user friendly. It's designed for the general public, and and other places would be like kind of like Mayo Clinic would be fine. There's some good ones out there that you can use, but I would start with the American Heart Association.
But I mean, in the room, people come to you and say, "I saw this online." Does that happen for every patient, or half, or frequently? And how does that affect how you treat people or how people receive care?
I don't know about you. I kind of expect it.
Oh, I expect it. I mean, let's be honest. I do it for my own self. And I I can only speak for myself. I can't speak for anybody else, but I'm glad that patients are Googling because it means that they're taking an investment in their own body and their own health. I don't want them to get overwhelmed by it. I don't want them to, freak out about it. I want them to come in so that we can assess it and evaluate it. But, they're taking interest. They're trying to learn about it. So yeah, if you come in and tell me, oh, I Googled this, I'm really worried it's this. Great. Let's work through it. Let me allay your fears. Maybe it is that. And then we do what we need to do to fix it. But I don't get bothered by it.
Yeah. It's just, it's just like anything on the web. It's when you go down those rabbit holes, and that's when it's like, oh, let's step back.
Right. I mean, and we all know that WebMD is going to tell you that it's nothing or you're dying. And so most of the time, you're not dying. Most of the time it's something in the middle. And I think that for anybody, medical or non-medical, that's something to remember, that most of the time you're not dying. That WebMD is every single time, regardless of what you're Googling. If you look on WebMD, it's going to say you're fine or you're dying. And it's somewhere in between.
Yeah. So get that investigated and see what it is.
Yeah.
But I think you guys are the experts though. Like I'm one, like there's got to be people out there, and this is Jeremy, the podcaster. What do I know? Like that are like doing that. And they're like, oh, I'm fine. They'll do that research and research there. I'm doing the air quotes again. And like, oh, I found the answer that I was looking for. I'm not going to call Emma or Becca.
And you can go online and find out the answer you want.
Yes. That's the other thing too, is if you're looking for a specific answer, you will find it.
Yeah.
Regardless of how far deep down in the internet you go.
And it's that, oh, I found it, and it might be based on two people's anecdotal experience, and so that's going to happen.
And if that's okay for you, that's fine. That's okay for me. Like I'm here if it's not okay for you. And if you don't like that answer, that's where I come in.
We can't make people do things.
No.
Sure. Yes. Yeah. I guess, good point. I'm not like, listen, everybody out there, you should, yes, you read that, but doesn't matter. That's not.
Yeah. Right. You just, that's what the internet is. You can find people who agree with your point of view, on almost any subject.
Yeah. It used to be like, well, I went to the library and I looked in the encyclopedias and it said that an ulcer is not a big thing. Days gone by.
I use the card catalog to find the
Oh, yes. Catalogs. I still kind of miss them.
Right.
I don't.
No.
Still not quite sure how to use it.
I like that they've turned into seed banks.
Oh, yes.
Oh, yeah. Yes.
I think that's an excellent repurposing of
and they were
those.
usually like these beautiful little
they were.
drawers.
Absolutely. They smelled good.
Yep. They were very good.
So the kind of the corny question I have, and I'll make it somewhat interesting, was I asked those, are you able to mend a broken heart?
So I was so excited to see this question because it really gets into my nerdiness. Let's get that correct. So there's two parts to this. Yes, you can mend a physically broken heart most of the time. If it's an emotionally broken heart, that also usually we can mend. But the best part about this is there is actually something called a broken heart syndrome, which in medical terms is called Takotsubo syndrome. And it is where a big, huge stressful event it kind of stuns or weakens the heart. And you do have a physical manifestation in your heart of a, severely stressful event. And so that's why I get so excited because there is truly a broken heart syndrome. And it's temporary and most people recover from it. And most of the time the treatment is, what we call supportive cares. But as a former ICU nurse, I have had this happen several times to patients' family members. And so that's where I first started geeking out on it. And also the side note is it's called Takotsubo because the part of the heart starts to kind of look like a octopus, a certain type of octopus that the Japanese call Takotsubo. So
come on.
I told you I was going to nerd out on this. Like I get so nerded out on it.
I think he's making stuff up.
Hey, that you can Google. Right? Go Google that.
And I was thinking of it as a song, and I thought it would be kind of fun. Right, exactly. And as I was sitting...
Well, we got, the Gibbs. There were 3 Gibbs.
Right. But, I mean...
It's going to be Barry.
It does speak a little bit about, too, the importance of the heart, because as I wrote in my little notes here, there are not a lot of country songs about the liver. Or the kidneys. It's all, there's lots and lots of songs about the heart.
Okay, I will say here's my trifecta. I hate country music.
Ooh.
I'm so sorry.
Boy, the kale eating country music crowd is gonna light up my email. South Dakota.
Yeah. So I grew up in rural Minnesota, like egg country, and it was just I was surrounded by country music. I really don't like it. But my understanding from the little bit of country music that I listen to, like they drink a lot in those country songs.
So right? I was going to say the alcohol. And
okay, bad analogy. There's not a lot of pancreas.
But they're
country
singing.
Songs.
They're,
How about
they're drinking because of the broken.
Yes, there you go. Yeah.
Okay, so tied that back right back.
So I know we're yucking it up here, but I did want to say one thing that's serious.
Please.
I do want to talk about label reading for sodium.
Sure, yeah.
Okay. So when you always look on the back of your label and it'll say, so many milligrams. So recommendations are doing at least less than 3,000 milligrams per day. So you can look at the milligrams. If you have blood pressure or problems, less than 2,000 milligrams is recommended. However, that can be kind of overwhelming for people like trying to figure that out. You can look at the percentages, which I'm not big on looking at percentages, but for sodium, it's helpful. If it's less than 5%, that's very low sodium. 10%, you're okay. If it's over 20%, be very careful of how much you eat of that food. And definitely check the portion sizes, because obviously if you have 3 portions, it's adding up. So just kind of double check.
Other than you mentioned soup earlier, what are some other sneaky ways sodium is getting ingested?
Basically anything that's, if it's like rice-a-roni and, just any of those pre-packaged things. Frozen dinners tend to be very high in sodium. If you're looking at frozen dinners, less than 600 milligrams per dinner, that's pretty good.
And I think the thing to note is the reason why these foods are so high in sodium is because it's used as a preservative. And so these foods...
And it's for taste.
And taste, yes.
Yeah.
And so you're going to find them in that. That's why you're also going to find them in the canned foods as well. So you need to really watch those, because a lot of times it's pretty insidious. You don't realize that, I'm buying a can of canned green beans. Why would there be sodium in that? And then you get home, you look at it, and you're like, oh, wow. That actually has a lot of sodium.
Yeah. And so salt is the number 1 additive in the American food supply. Mm-hmm. So and we like salt.
Yeah. I mean, it tastes good.
Yeah. We like to really have a lot of it. So
the next podcast could be about how much sugar is added to the American diet.
Write that down. Sugar.
I think we talked about that last year.
We might have.
Because that is also fascinating. And actually the history of that is very fascinating as well.
Yeah. Well, and Becca.
I'm not volunteering myself.
Okay. I mean, Becca, you're right. I think in one of our previous podcasts that you've been on, we talked about that.
Yeah, we kind of talked about sugar addiction, and
which
it's in everything. And
right. And it was I wish I could pull out the name of the podcast. Was it a diabetes one we did? Maybe.
That was 2 years ago. I think we called it like sugar addiction. I think it was
there you go.
Sugar addiction.
I think you're right.
Yeah.
Thank you. So, but here's my last. Thanks for doing this.
Oh.
But I got a last question for you, and I'm going to ask you first, Emma. What's in your car right now?
Oh my God, you don't want to know. My car is such a mess right now. It's embarrassing how messy my car is.
Blame the kids.
I can't. It's all in the front.
What's one thing that's in your car?
My kids' skis are in the back. There's a couple of random socks in the back as well, because they take them off in the car and leave it there. And my sunglasses. I left them in there this morning.
Not bad.
That's not bad. Could be worse.
Becca, did you knew this question was coming? Did you change what happened? Like clean your car out before this? Or?
Typically this time of year, I permanently have my cross country skis in here in my car. Not this year. I have my walking poles.
Oh yeah.
Are in my car now because I've been doing some great hikes, but yeah, skiing has been pretty much nothing. And I want everyone to know the reason we got such a good winter this year is because I bought a season pass for cross country skiing last fall.
Well, I think we could debate that word good.
True.
But let's save that for another podcast.
March ain't over yet.
Right. Yeah, no kidding. Right. Any last things that I didn't ask that you would like to share before we wrap this up?
Yes. So I would like you to know that I just realized that Mrs. Dash seasoning is named because of the Dash diet.
Thank you for asking, because I
didn't know that.
I didn't either, but I had to Google it.
That's great. Well, it makes sense.
It makes sense, and I never put two and two together.
Oh, that's funny.
Wow.
Excellent.
Thank you for that.
Thank you both so much. Really
Yeah,
appreciate
thank you.
the time, and look forward to seeing you again. Really appreciate the time.
You're welcome.
I've
Thanks for
enjoyed
inviting
it.
us.
So thank you.
Awesome. Have a great day.
You too.
All right. Bye. Watch your sodium, everybody. When was the last time that you got your blood pressure checked? Has it been a while? We can help you with that at NorthLakes. Give us a call. NorthLakes Community Clinic is a federally qualified health center with locations throughout northern Wisconsin. Our mission is to respond to the healthcare needs of our communities with an integrated array of quality services and to actively remove barriers to wellness. Our doors are open to all people. Learn more about what we do by visiting our website, nlccwi.org. My name is Jeremy Oswald, and I'm a marketing and communication specialist here at NorthLakes. Please review this podcast. It makes it easier for others to find us. We appreciate that you took the time to listen. Have a great day, and thank you very much.